Good morning and welcome to the gathering here. My name is Jonathan Matthew. I am the VP of Research and Compliance and Chief Economist at the Center for Improving Value in Healthcare, or CIVHC, here in Denver. This morning, we've invited lots of folks to join, and we've got a good group here in the room and a lot more taking advantage of the remote webinar option. But we've invited all of you to join us here today to hear a little bit about some work that we've been involved in. Thanks to our partners at the Network for Regional Healthcare Improvement, and my colleague Stacy Donahue is here, and we'll talk a little bit more about Henry and the project in general in a minute. But we've been part of a grant with the funded by AHRQ through the Patient-Centered Outcomes Research Institute, or PCORI. They awarded 3 U19 grants, one of which went to Harvard and NBER, the National Bureau of Economic Research. And the sort of, again, much more on this from Stacy here in just a minute, but the purpose of the grant is to look at differences in adoption of PCOR-based evidence and performance based on quality and cost measurements, depending on whether or not a practice is owned by a system or part of a health system or independent. So this is kind of the core question of this particular project. And Harvard and NBER are kind of looking at this at a very high level. They've asked 4 states to participate, and again, much more on that in about the next half hour or so. And then we'll get to the really good stuff. We'll start talking about the results. We're going to throw up some comparative results for 8 quality measures for 4 different states that are participating along with Colorado in this particular project. So again, kind of I think the agenda does a nice job of summarizing the purpose. We're here to present some information on variation in quality measures across 4 states participating in this project. And most important of all, I'll emphasize this a couple of times during the course of the next couple of hours, we want your feedback. What we're doing, why we're doing it, how we're going about it. When we get to actually showing some of the results, which are in the handout, your reaction to those results, some of the factors that might explain Colorado's performance relative to the other states. But, you know, the number one goal here this morning is to really get your feedback on what we're doing, what it all means, and how we can make the work more meaningful over the next couple of years. This is a 5-year grant opportunity. There was some question about whether or not there would be funding for this year, year 3, or if it would be greatly reduced funding. So we've overcome those challenges. There's no guarantee of funding in years 4 and 5, but we're 2 years into this. We're about to start year 3, and we felt this was a really good time to bring folks together, let them know what we're up to, show them what we're finding and what we're seeing in the data, and to get some really good feedback to help chart the course for the next couple of years. Similar meetings have already been held in Oregon, in Utah, and in Massachusetts, so we're the 4th state to hold a stakeholder meeting like this, and we're very excited that you're all with us here in the room. I'd like to start with some introductions for folks in the room. Because there are a large number of people on the phone, sorry phone people, we're not going to give you an opportunity to introduce yourselves, but I'll start with my colleague, Command Osborne Roberts, to my left. If you could please just provide your name, the organization you're with, and or your interest in this work. Keep it very brief. That would be fantastic.
Good morning, everyone. Sorry I'm a few minutes late. My name is... There we go. Good morning, everyone. My apologies for being a few minutes late.
That's beside the point.
I'm a doctor, it happens. Hi, Command Osborne Roberts, Chief Medical Officer for CIVHC. Clearly interested in this from a professional standpoint, but also from the standpoint of the improvements in care that allows folks like myself to give our patients.
And I'm Jonathan Matthew. I'm the lead investigator for this project for CIVHC. And as you introduce yourselves, please push the button, make sure you've got a green light so that everybody can hear.
Good morning. I'm Stacy Donahue from the Network for Regional Healthcare Improvement. I'm excited to be here today and excited to talk with you about the project.
My name is Paul McCormick. I'm an analyst with CIVHC, and I was responsible for a lot of the technical aspects of the project.
Good morning, everyone. My name is Maria de Jesus Diaz, and I am the Quality Measures Program Manager for CIVHC, and I work in this project with Paul and Jonathan, just talking with all our partners and making sure our measures are relevant and here.
My name is George Swan. I'm a retired hospital administrator, and I've been dedicated, advocating data transparency in healthcare to create a comprehensive data portal where you could actually go and find one place where you could get, for the most part, macro and micro data. And, it's good to be here.
Good morning. My name is Good morning. My name is Mike Fields. I work with United Healthcare in our regulatory and financial operations, and collaborate with folks like Jonathan and Maria in supporting our national delivery of data.
Good morning. My name is Chet Seward with the Colorado Medical Society.
Hi, my name's Jack Berry. I'm a retired rural family physician. Also past president of the Colorado Medical Society, but I am long removed from the Medical Society in that I'm out of town during all their meetings because I'm hunting and fishing far away. I interview for admissions at the Colorado School of Medicine, and you would not believe the questions I get from the interviewees and the amount of insight they have about with questions about the healthcare system, what it's going to be like in the future. I'm not able to answer them because I don't know what's going on, but I'm here today to get a clue.
My name is Edmund Toy. I'm a director and economist at the Colorado Health Institute.
I'm Jessica Lennart. I work for Colorado Para, and I'm here with the purchaser mindset.
And I'm Alana Festa. I'm with IMA, and I'm acutely aware of the disparity in quality and excited about any valid information that can be shared to empower some different decision-making when purchasing healthcare.
Caitlin Westerson with the Colorado Consumer Health Initiative. We're an advocacy organization that represents consumers in health policy.
My name is Carrie Frank with Civic.
Bob Smith, Colorado Business Group on Health, have an interest in the value proposition in the marketplace.
Mark Latos, Cigna's Chief Medical Officer for the Mountain States, with a fairly apparent interest in cost and quality of care.
My name is Chris Cleany with Center for Health Progress.
Jeff Sugar is an actuary at Kaiser Permanente. Very interested in this one.
Dustin Moyer with the Colorado Health Foundation.
John Van Gulik with the CPI Group. We do a lot of work in regional and rural healthcare.
Maria Craven, faculty at University of Denver.
Pat Cook, Colorado Gerontological Society.
I'm Dick Thompson with Quality Health Network from Grand Junction and a member of Civic's board.
Eddie Costner, account executive with Civic, really interested in hearing everybody's feedback so we can better learn how to leverage the APC claims data.
Great, thanks everybody. Those are all the folks that are currently gathered in the room. Stephanie Spriggs has not introduced herself. And Steph, do you have any other instructions at this point for the folks on the phone and how we're handling chat and all that stuff?
Right now, everyone on the chat, we are using the chat box for questions.
Also, if you have any concerns or questions as this goes on, you can feel free to email me at S as in Sam, P as in Peter, RIGGS @civic.org, and I'll do my best to moderate what I can from there as well.
Thank you, Sam.
Okay, it is now my great privilege to introduce Stacy Donahue from the Network for Regional Healthcare Improvement. She's going to provide some background on ENRI, as they are known via acronym, as well as some background, sort of high-level background on the project as a whole. After that, Paul and Maria will provide some background on, or a little bit more detailed information on Civic's role in this project. And then, as I mentioned, we'll get to the really good stuff and start talking about the results and have some back and forth and hopefully get lots of good feedback from you folks. But for now, Stacy, please.
For now, we have to get through this stuff, and then we get to the good stuff.
Okay.
All right, that sounds good. Fair enough. Thanks, Jonathan. So Jonathan already did a great job setting the stage of why we're here and what this project aims to do. As mentioned, there's a whole portfolio of projects under this ARC funding, and it's helpful, I think, in understanding some context for the other projects to know kind of the bigger picture opportunity of this work. Good, same slide. So oh, we can go back one, sorry. Yeah, thank you very much. So as Jonathan mentioned, this is in partnership with the National Bureau of Economic Research and Harvard Medical School. We're really appreciating our partnership with them, as well as the other project teams, which are led out of various academic institutions. One of the projects that overarches these 5 projects that you see up on the slide is a data core project. So that project is aiming to bring together a national database of information on health systems, hospitals, and providers and practices across the country, and capturing really important attributes such as system ownership. So that is kind of the key underpinning of all of the projects. The first project, Project 1, Delivery System Structure and Outcomes, they have a number of research topics. One that they've looked at recently is the impact of the 340B drug discount program and how that's led to affiliations between hospitals and provider practices, and how correspondingly it's increased drug utilization. So looking at kind of that entire evolution, as well as impact on utilization and cost. Project 2 is our project. I'll talk a little bit more about that in a moment. The third project, Characteristics of High-Performing Delivery Systems for Cancer. So one of their most recent topics is looking at variation in end-of-life care for Medicare patients and seeing where there's variation in geography, variation from a systems perspective in that care that's received in the last 6 months of life for patients with a cancer diagnosis. The fourth project is Pediatric Performance of Health Systems. So they've been looking at how socioeconomic background impacts access and quality of health care for children. And Project 5, Causes and Consequences of Institutional Consolidation. One of their recent topic areas is understanding the consolidation of dialysis providers and its corresponding impact on certainly costs, but also quality across the country. So really, really fascinating kind of suite of programs, several of which have published. For all of these projects, there is an ARC definition of health system, which we could probably debate all day long, but it is the definition for this particular project and does require a hospital and physician group ownership relationship. Doesn't mean we aren't looking at other relationships as well that don't involve ownership. So our project, Project 2, we're working in understanding cost and quality performance across these 4 states that are listed here, of course, including Colorado. And these 4 states were chosen based on a whole host of different reasons, but one being there was an expectation that there would be variation in care delivery and cost and quality across these 4 states. As Jonathan mentioned, we've identified some quality measures that we think are meaningful for this research, and we'll share those with you today. We'll share the initial results with you today. And we're also starting the work to look at the results in relationship to that data core that I mentioned, so we can really understand how performance varies for providers that are attributed to a system versus those that are not attributed to a system, and start really understanding health system variation. Okay, so now I turn it over to Paul, and he'll talk about the process of pulling all these data together.
Thanks, Stacy. I won't get too into the weeds here, but I'll give sort of the high-level breakdown of what we did. The first thing that we had to do was decide, do we have the data we need to produce these measures, and can we pull it? So we went to the data and we looked at it. We looked at 2014 member eligibility, full medical coverage, so we're not looking at a partial view of somebody's health picture by looking at just a behavioral health plan. So we're looking at full medical coverage, 2014 commercial data. Then we also looked at the quality of the data. As you might imagine, these APCDs have a lot of different payers sending data in different formats. Occasionally we have challenges. We wanted to make sure none of the issues behind those would find their way into influencing these results. So once we had the right data, that was a good first step, but we were still looking at 4 different APCDs, 4 different extracts, which is why we developed the Universal Data Store, which is a SAS database, same platform for all the states, using same tables, same columns. The advantage to this is that now when Massachusetts says here's one record for one member, that means the same thing in Colorado when we say one record, one member. The other benefit to that is that it really did improve the quality of the data. When you're forcing everything into that common format, you make sure everybody is applying the same standards of quality across all the states. Have the right data, have the right structure, that enabled us to develop the quality measures independently. So each of the states took 2 measures and wrote the code for it. Then we shared it, tested it, all that kind of stuff. And that was a really awesome benefit because it meant we didn't all have to do the same work. And it also meant that we could test it and really make sure it was working as it was intended. So that was, I think, a great approach in this. In addition to the measures, we wanted to look at cost. So to calculate the cost and make them understandable between the different states, we ran cost measures and then sent all the results. Each state sent the results to the technical lead. Technical lead did a risk adjustment for age and gender, and then sent those factors back, which we then reapplied to our cost measures. So we ended up with a really nice risk-adjusted cost results. Let's see. Finally, we have good data, we have good measures, we have good cost data. We wanted to run some different splits. So in addition to the system in and out piece, we looked at geography, and we used CMS county types. We rolled those up a little bit more into just 3 categories. We ended up with large, metro, metro, and then rural. And those are the 3 geographical divisions that we ended up with in the data. And I think when we looked at that, it really made the most sense to cut it into those 3 big groups. And that's where Maria started to see some things of interest.
So yeah, with all the data and the work that the technical team has done, then we had a consensus measure set. This consensus measure set was developed over the work of a year of discussion among the states. And what they discussed basically was first, like what was the set of relevant measures to all of the states, and relevant in the sense of how much they align with the goals that the state had. They were looking for measures that were nationally recognized. They were also looking for measures that were part as much as possible of the state local initiatives, and that was another part of the decision. And of course, again, measures that had enough variation so we could actually see something of interest in the effects of systems and the difference in the states. And of course, these have to be measures that can be created by claims. That was very important. So they all use the medical and the pharmacy claims that we had available. And they are also a good representation of pediatric and adult measures. As you can see, the first three measures, chlamydia screening, adolescent welfare visits, developmental screenings, are all pediatric. The measures that follow are, we call them, just to aggregate them in a nice category, we call them preventive measures, the first three. And the second three are prescription-related measures, so prescription-based measures. And these are for all population adults. And then we have the two AHRQ measures, which are hospital admission for ambulatory sensitive conditions and chronic conditions. We are not going to talk about the results of those because since Paul explained, we used only commercial data. Really, the numbers for those measures in this population are very low. And we are just going to focus on discussing the first two sets, the preventive and the prescription-based measures. So that's. And now the good.
Let's take a little quick pause here. I think we'll take a break before we jump into the measures, but I'd just like to pause here and see if folks have any questions about what you've heard so far, sort of the purpose of the project, our role in it, and kind of what we've done. We've tried to give sort of a high-level overview of the what, the how, and the why, but I'd like to pause now and see if folks have any questions. I've got a couple. Yeah, go ahead and cue your mic. Perfect.
Just first, really quickly, you talked about the data scrub process. What percentage of the data fell out when you did that scrubbing?
That's a good question. I'd say I would estimate it at maybe 20%.
Okay, that's not terrible.
It wasn't bad.
Okay.
And some of the reasons why we kicked people out of the analysis, so to speak?
Yeah, it was primarily because of eligibility issues, where we'd be missing eligibility records, but we'd have claims and that kind of thing, so we knew that something was wrong with that data. It was payer-based, though, that we would either include or exclude.
Yeah, another consideration was you want full coverage insurance plans. So you want to throw out the supplemental plans, the dental, the vision only, those kinds of things. So we went through a similar process with the total cost of care work that's funded by Robert Wood Johnson, another project that we participate in through ENRI. But, you know, you want to make sure you're making comparisons that are as apples to apples as possible at the end of the day. And so you only want to include full coverage insurance plans that have relatively stable patterns of numbers of people, numbers of claims, volumes of dollars, and per member per month or per member or per person per year patterns. You don't want to see big fluctuations in eligibility from one month to the next. So those are the kinds of things that we try to be very, very mindful of as we determine what plans will be included in these types of analyses and which ones we may need to set off to the side, either because they don't provide full benefits or because there are some data anomalies that we see in their submissions.
My other question, and at the risk of kind of opening Pandora's box a little bit, so I'm sure a lot of work and debate went into choosing the consensus on what measure sets to use. Can you maybe give a little bit of more information on why those particular ones were chosen? I'm trying to phrase this correctly, but why you believe those to be representative of, you know, kind of a whole picture?
Well, for example, the adolescent welfare measure, the chlamydia screening, and the developmental screening. Well, the first two, the chlamydia screening and the adolescent welfare, are measures that are followed by the ACOs or equivalent to ACOs in Oregon, and they are also performance measures for the Health First, the Colorado Health First program, Medicaid program. So that's important. And they were also for Massachusetts and they were also for Utah. So that's the reason they were chosen. They were like common measures for the state level programs for all the states. Developmental screening was also a measure for at least 3 of the states, and the other measures were the same case. So that is the reason.
So it was more about what were common among states, not necessarily what will provide a holistic view of kind of quality overall.
Yes, and well, also this is like the first step in the project. This project is not ending anytime soon, and the idea is that we will keep developing measures in the future. But this was the first consensus set based on what is common to all the state level programs, or to most of the state level programs.
Got to start
Anything else?
Yeah, exactly. We had to start somewhere. And Stacy, do you have some other thoughts on this?
Yeah, I mean, it is starting somewhere. So starting where there were common interests, and there was a sense that there would likely be some variation in these measures. They're not necessarily the go-to measures that you see in a lot of studies. So this team was digging a little deeper of what else can we look at. So came up with what we thought was a pretty interesting set of measures.
It was ultimately Harvard and NBER had a lot to say about what the final choice of measures was. And if you have that holistic set of quality measures, please share. I'd love to know what that is.
Dang, I should have kept my mouth shut.
I think I saw two other hands back there. Yeah, please just key your mic and go ahead, please.
So since this is these are commercial results, that would exclude Medicaid, and it would also exclude CHIP.
Yes.
And because of the need for consistent data, this would also exclude people who potentially went on and off of Medicaid or CHIP. Is that right? Or if someone doesn't have consistent enrollment for a year, are they still going to come up in these measures?
It depends on the measure. Some of the measures had a limit, and some of them didn't. We didn't pull the data if they were outside commercial, and so if the data wasn't there to qualify them within commercial, it didn't produce a result.
And there is a discussion of expanding this analysis to Medicaid. We've had a lot of back and forth about that. The team at Harvard and National Bureau of Economic Research, NBER, have assembled. They have a national Medicare data set, so there will be the results of analysis related to the Medicare population released as part of the overall 5-year study as well. I thought I saw one other hand back there. Yes, go ahead. Good. The focus was just placed on commercial for the initial round of analysis. It wasn't that we excluded it for any particular reason. It was a let's start here and see what happens. Others? George, did you have something? Just key your mic and go ahead. Yeah. Microphone. Mike.
I think the whole issue about like how many measures there are, so the manual of the NQF, has a couple 100,000. There's a great book that was written by the Institute of Medicine on the vital measures, 200 pages long, that contains all kinds of stuff. The real question is, there are a lot of other data sets around, and oftentimes they can be a great context for the specific things that you're measuring. So you ought to consider, bringing in those context data sets and, making people aware that there is a huge amount of work that's been done on this for years.
And that's a great point, and we did a lot of that. Obviously, when we got the initial round of results from the 4 states, we said, all right, does this make sense? And so we did a lot of going to other data sets that had these same measures or very similar measures calculated based on other data. And we compared our results with those and found in a lot of cases they compared very, very favorably. You don't often get one-to-one matches in these situations, but, as soon as we had results in hand, the first order of business, I'll let Maria expand on this, was to say, how do these numbers compare to what we see based on other sources? Maria?
Yes, we compared our results, the results obtained with this data set, with what is available from NCQA Compass, and also with the reports available from Medicaid. And particularly the preventive measures compare almost exactly for the state for the year. Some others were not as close, particularly the antidepressant management medication, but we had to keep it. We did a lot of research on the integrity of the code and the measure, and we had to keep it comparable to the code of the other states. And to the other point about integrating other data sources to give context, I think that is part also of the aim 3 of the project. They are putting together this data set that is going to include also socioeconomic backgrounds of all the population that is being analyzed in the different states. And at the end, to produce a much more sophisticated model that actually can give a little more explanation on the outcomes of quality and cost for the different states.
Anything else? Yeah, Mike.
Mike Dilson, Healthcare. So I'm wondering on the data set itself, would there be an opportunity to at least understand what the data elements or the comps within the data set? Is that, I don't want to pry, but I'm interested. And I'm thinking about the CDL and the relationship between the data set that was commonly agreed to and used as the basis for these measures and how that evolved. I'm sure there was a lot of conversation around that. So understanding that relationship between the 4 states, how it was leveraged to actually produce actionable information, and how that might be potentially relatable to the CDL exercise, and potentially presentations on that.
Right. I think the actionable piece is a little ways down the road, but we're working. The 4 states are working together with Emory and Harvard NBER to put this in a format for publication. With a sort of a summary of key findings and that kind of thing. I think this, along with the total cost of care work that we also participate in under Emory leadership, is demonstrating in a very practical way that it's possible for multiple states with disparate databases to come together and generate results in ways that allow for meaningful comparisons between them. And I think that's a really exciting development. As you know, there are national sources of claims data out there. They're often limited in terms of the level of granularity in the data with respect to providers or getting enough PHI to assign unique patient identifiers so that you can follow people through the database over time. The state databases generally have a much higher level of granularity and detail in them, which means you can leverage them to do total cost of care on an attributed patient basis at the practice level. And so that's really exciting. And again, this project on total cost of care is demonstrating that states can come together and overcome the differences in their data sets and do some of this, what we hope will ultimately be very insightful and actionable analysis. The CDL, I should mention for folks listening as well as here in the room, is the common data layout. And there was a Supreme Court decision just not quite 2 years ago that said that states cannot compel self-funded health insurance plans that are regulated at the federal level under a law called ERISA to submit their data to state claims databases and other similar data assets. And a bunch of states that were getting that data no longer are as a result of the Supreme Court decision. Well, in that decision, Justice Breyer said, hey, Department of Labor, you have authority to regulate here. And if you were to adopt a common data standard, a common data layout, or a CDL, and through regulation, say to the ERISA-regulated self-funded plans, you will submit your data once a year in this common data layout, we could overcome all of this. This is not a decision, his argument was, this is not a decision for the Supreme Court to make. There are federal agencies that have regulatory authority in this sphere and stand up and regulate, or stand up and do your jobs. We were making a lot of progress working with National Academy for State Health Policy, NASHP, the APCD Council, National Association of Health Data Organizations. Henry was involved in this work as well. And we did come up with a common data layout, a standardized claims data submission format. We presented that to the Department of Labor, and nothing's moved since January. So that process, the good news, I think, is it brought lots of people together to think about how we overcome this limitation on the data that we're able to collect. And I think, people are coming around to the realization that it's going to take very comprehensive data in order to really provide a full picture of what's going on in healthcare markets and to be able to identify solutions based on actionable information. Kind of a long answer to your question, but I think it's important for people to understand what the CDL is and the work that's going on kind of behind the scenes there. Anything else, guys? Do you have a question from the?
We have a question from online.
Okay.
I can't speak to the previous question myself. All right. So the first question is, did these studies take into consideration what insurance covered or did not cover?
We did get into benefit design. Generally, claims data doesn't include information at that level of detail. We know what the patient paid. We know what the plan paid for these services, but beyond that, we can't really speak to individual plan coverage, generosity, or what have you.
Okay. Another question: Does the data include fully insured and TPA type, and which carriers were used? Is there more cost associated with one carrier versus another in the area studied?
It varies from state to state, the inclusion of fully insured versus self-funded or self-insured plans. Generally, because it was 2014 data, the Colorado data set only reflects fully insured, individual, small group, and large group, but that's likely, all but certain, that's different across the other states that we're collecting self-funded data or have been collecting self-funded data for longer. We did not make an attempt to differentiate between commercial insurance types. It's commercial insurance to the best of our ability, as I mentioned earlier, limited to full coverage plans, removing the supplemental plans and other forms of partial coverage, but this is limited to commercial all lumped together, but it would, I agree, I think the point is it would be really interesting to see whether there's a difference across self-funded and fully insured commercial plans. I think there are a lot of folks out there who suspect there may be.
Okay. And in regards to insurance companies, will this study eventually change whether or not they can deny care, making it a across-the-board quality of care?
I'm not seeing a direct connection between these results and decisions regarding whether or not to allow care or cover certain types of services. I think that's something probably worth exploring, but I don't. All right, so just to kind of tee this up a little bit, onto the results. We saw pretty significant variation in all measures across the 4 states. Some interesting results, I think. We also, not only did we spend a bunch of time sort of validating these results against other sources of similar information and found that they compared quite well, we also spent a fair amount of time looking at some of the outliers or some of the anomalies and thinking about what sorts of policies, reimbursement structures, and so forth that were in place that would explain some of this. So, we have some thoughts on what helps to explain some of the Colorado results. And Stacy, have you been at all 4 of these now?
3 out of the 4.
So
yes.
Stacy's attended 3 out of the 4 state meetings and has some insights from Oregon and Utah as well. So without further ado, I'm going to turn this over to CIVHC's Chief Medical Officer, Tanan Osborne-Roberts, and we'll start with the preventive care measures, which you see up there on the screen, the chlamydia screening, adolescent well care visits, and developmental screening for the first 36 months of life. Like I said, I'll turn this over to Tanan, but we're very, very interested in hearing your reaction to these results and taking questions on how this is piquing your interest or potentially raising some questions. See that.
So, good morning, everyone.
I guess we got
we have
a hand up already.
Start.
Yes. These are rates that were observed within the commercial population that was included in the study in each of the 4 states. Yep.
So as we move along, so first of all, good morning, everyone. Oh, come on. Folks on the phone, I know you said good morning, too. Sorry, I like to wake everyone up. I've been told I have a voice like a jazz DJ, and you'll all go to sleep if I talk too long. But the long and the short is that the results overall are pretty interesting. And what I'm going to direct everyone to do as we're running through this is to really take a look at handouts 3 and 4. 3 is really the top line. And we'll give you the view from maybe not 50,000, let's call it 25,000 feet. And if you're looking for some of the definitions as to exactly what was being looked at in regards to these specific measures, a lot of that information is available on the side bars of handout 4. So if you're looking for specific definitions of what any given one of these percentages and rates and measures looks like, it's there. And I'll be discussing those really as we go through. But really overall, let's go ahead and start with the commercial results, preventive care measures, chlamydia screening, adolescent well care visits, and developmental screening for the first 36 months of life. And it should be pointed out that for all 3 of these particular measures, we're looking at the percent accomplished within a specified time period within the commercial payer population, as was discussed. So in looking at all of those, I'd like to point out that Colorado is in blue because we are blue sky country, and Utah's green, I suppose, for the Green River. But the long and the short is that Colorado is to some degree kind of roughly within its peers, maybe slightly ahead on 2 of the measures. Its peers being Oregon, Colorado, and Utah. From a geographic and population-based standpoint, but is behind Massachusetts, by a substantial amount. And we'll certainly kind of discuss Massachusetts, its inclusion, and why it might be an outlier in a positive fashion on some of these measures as we go along. The other thing that you can see is that under developmental screening for the first 36 months of life, Colorado is by a large factor the positive outlier. And there are probably some specified reasons for that. Again, ones we will discuss. But before I move on from the top line on the preventive care measures, does anybody have any questions or comments? All right. Well, let's get into the nitty-gritty. First.
I think we've got a question from the chat box. Oops. Were we able to segregate limited network versus full network? Regrettably, the Colorado APC does not have data historically on whether a provider is in network versus out of network. We are, however, collecting information starting in 2015 going forward that captures that information. Do the 3 other states lack self-funded data? Again, that varies from state to state. Generally speaking, the other states do have some self-funded data, but that vary. Again, you've seen the old saying is you've seen one APCD, you've seen one APCD. Colorado does not have any self-funded data in the APCD prior to 2015, and it varies across the other 3 states, so there's no neat, clean answer to that.
All right. So moving along, let's go ahead and dig into the nitty-gritty, unless there are any other questions. All right. Next slide. Adolescent well care by geographic region. One of the really wonderful things about this data is that we can look at the data in a range of different slices. And one of the more interesting ones in a state such as ours, as I'm sure you're all aware of, is looking at your tall buildings versus wide open. Because that's one of the substantial geographic and political divisions, if you will, in the state. And as you really kind of look across adolescent well care by geographic region, in not simply our state, but the states all along, you tend to see very, very similar pattern, which is that adolescent well care tends to be being accomplished at a higher rate in large metro and metropolitan regions, and at a lower rate in the rural regions. Does anybody have any thoughts, ideas as to why that might be? From a consumer standpoint, from a clinician standpoint, from a standpoint, because that is sometimes how it is. We need the data to tell us what we already knew so that somebody will listen to us. At the end of the day, any thoughts around that? Oh, I heard a word out there. People are not raising their hands.
Access to physicians.
So we have access as a possibility. I saw another hand back here. So education around access in addition to access itself. Any other thoughts?
Are these measures more indicative of the actual population behavior versus physician quality?
I think that's an excellent question. These specific measures, the adolescent welfare, might be a better indicator of access. Of course, it is also an indicator of system or physician quality, because practices tend to, or let's say if you have good standard procedures, you will want to outreach your population and make sure that all the population that is attributed to you or is in your service area is receiving appropriate services. And based on the standards, we know that all children need welfare visits at a certain time, at a certain periodicity, and in the case of adolescents, it's not a difference. It's not a difference. So it is both. I think it of course, it speaks of the practice, it speaks of the system, it speaks of the provider. It's not completely detached from the population.
Well, adolescents think they're going to live forever.
True, but apparently less in urban areas. Please.
If you do the folks on the phone a favor and repeat the comments and the questions before our folks address them. We're just having some spotty audio.
Got it. And also, I'd just like to remind folks before you speak, make sure to hit that microphone as you can. Dr. Latham.
Thank you. These have popped in my head. I've got no reason to believe one way or the other that these are right. Number one, the motivation of a physician's skill accurately based on geographic location. What is their incentive based on? Number two is not just the access to doctors, but the ability to pay for the doctors. And number three is cultural. In a rural setting, are people more likely to be more self-sufficient and say, I don't need to see a doctor?
Got it. Other thoughts?
Having practiced in that environment, I can tell you that Mark's last two items are the predominant factors influencing this. And if you notice, Colorado and Utah are very similar. And that was the first thing I noticed as I looked at these. And they are similar cultural environments. Farmers don't bring their kids to see the doctor for an adolescent well-child checkup. They just don't.
Imagine that in Utah there was a pretty hearty discussion around these measures.
Yes.
In part because they were the lower performer in comparison to the other three states, and the discussion was around the cultural aspects, including religion.
Yes.
And how that plays into the stigma of chlamydia screening, for example. Adolescent well care visits in terms of their comments about families with a large number of children and experienced parents who may not opt for the same level of preventive care services because they have experience.
I think you're dead on.
And then with developmental screening, there's lots of discussion from a coding perspective. So we thought that was quite interesting in terms of whether or not that screening may occur in the course of the visit, but there may not be incentives in place that would incent the coding of the screening element to be captured in claims data.
So we have one, I'll get a quick question in from the folks that are attending remotely. What is the thought on why Massachusetts is showing consistent higher numbers to this point? A number of things. As I mentioned, we did not only our validation of our individual numbers, but we took a look at outliers, and Massachusetts is the positive outlier on just about every measure. As we heard from the folks at Mass Health Quality Partners, the NRA member in Massachusetts, they've been doing quality measurement reporting in Massachusetts for over 10 years. And so a lot of these measures were already in use in Massachusetts, have been for a decade or more. Physician practices are tracked on their performance on these measures and have been compensated based on their performance based on these measures for a long time. Some of you may be familiar with the AQCs, the Alternative Quality Contracts. This was a program that started probably pushing a decade ago. Blue Cross Blue Shield of Massachusetts started this. The program now includes basically all of the providers in Massachusetts who are seeing patients under Blue Cross Blue Shield HMO products. And so it's a very large number of Massachusetts providers and patients. They also reward or compensate based on performance on these and a long list of other measures. So the short of it, in terms of Massachusetts, is positive outlier. They've been tracking these measures for many years. They've been compensating practices based on performance, based on these measurements, and that accounts for an awful lot of the outlier status. The other one that I would mention very quickly is developmental screening for the first 36 months of life. When we saw this, we were surprised. I reached out to David Keller at Children's Hospital, who some of you know, and David said it's a very simple answer. We're well paid for that. And he said, we're not as well paid now as we used to be. Several years ago, there was a very big financial incentive, or a relatively large financial incentive to do these things, and pediatricians in the state of Colorado were very responsive to that financial incentive, and they continue to be based on this analysis. So that related to the Massachusetts question, I think explains Colorado's high performance on that particular measure. Yes.
I just had one follow-up about cost. Most of these preventive measures should not cost the patient anything, so cost shouldn't be an issue from that perspective. Though it might be that people are still not aware of that, and in Massachusetts they are. That enrollees are used to the idea that they don't have to pay for that.
So actually, before we continue the discussion, since we're actually already getting a bit ahead to the other measures, let's actually just kind of run through the granular data for them. Okay.
So I'm sorry to interrupt, but I just want to point out the 13% in Utah, the developmental screening. So one other point that I wanted to make, and I think also points towards the outlier on the Massachusetts side. In Utah, we found, the reason I asked for the correct thing, I was sitting next to a pediatrician who was also the lead medical director for their practice. He brought up the point that although we're talking about commercial population, Medicaid policy has an impact on commercial population. In the state of Utah, and no one can tell me why, developmental screening for the first 36 months of life is not covered under Medicaid. So conversely, as Jonathan was referring to, Massachusetts has an incentive built into it or had previously. So, and you're talking about 2014 data. So that disparity in part is financial. And when I asked the physician who I was sitting next to, if he could explain why they would not do that for a commercial member when that's only impacting Medicaid, he said they're not thinking about that when they're talking about patients. What they do know in the back of their mind is that it's not covered under Medicaid. And frankly, no one could answer the question of why it's not covered under Medicaid. Thank you.
Oh, got it. So just running through the other two, since I think we're probably going to discuss these a bit more as a bundle kind of going on. If we take a look at the next one, chlamydia screening by geographic region, again, you see essentially the same pattern. And it's actually even a bit more clear here and a bit more cross-state here than even for the previous measure. And really, once again, developmental screening by geographic region, you see the same pattern, but with the caveat that Jonathan had discussed, likely secondary to incentivization here in Colorado, and as we're hearing, possibly disincentivization in Utah as compared to Oregon and Massachusetts, who are relatively comparable, with some variances that might be explained by some of the factors that we're discussing overall. Any other thoughts on these numbers or this bundle? So what I'm hearing overall is that folks are coming up with a range of different reasons for why you may be seeing this. One is access. One is education. A large one clearly is market forces that are pushing for particular sets of incentivization or not. Something that I think I'd like to put out there that folks are circling around but haven't quite landed on, if you will, is infrastructure. I as well have worked the majority of my career in rural locations. I do currently, actually. I'm out in Brighton, most of the time for my clinical work. Aside from the basic, thing where a farmer won't come in until his arm has been chopped off by a combine, which you do see, you really overall there's a very, very different set of infrastructures that operate in a rural environment that operate in urban one. And it's a bunch of small things, but which can potentially add up. For instance, does the rural environment have one large institution that's particularly interested in any given one of these screenings or not? That's a question that will come up. A lot of them don't, frankly, as compared to a number of the metro areas which may have an academic center or another institution that pushes these sorts of things. You look at the infrastructure in terms of provider amounts. You look at the infrastructure in terms of what ancillary sorts of public health department activities may or may not be available in metro versus rural areas. You look at what may be available in regards to NGOs pushing certain types of interventions in rural versus urban areas. Overall, I think what you can see in this trend is maybe the collective effect of a number of those sorts of things. Any other thoughts?
George, thank you.
This data has a context as well, and one of the significant ones would be your STD rates out of the Communicable Disease Department of Public Health. And, it just seems like that would be pretty relevant, too, to help inform stakeholders about the value of chlamydia screening, as to what is the actual occurrence rate in a population area. You could get that information from public health.
Good point. Another point back here.
I've often wondered if there is any kind of correlation on the data done around whether there's education done on what these things can do. So I'm a longtime healthcare CIO, so I have access to a lot of this data. I understand all the data and what it means, what the percentages are for all kinds of diseases, because we've done, and I worked at a company that got acquired by DaVita that is really good at manipulating this data to keep the patients healthy. My feeling is, but I don't have any data to back it up, is that this education isn't strong. Like, why, if you're 14, do you need well care? Well, I'm healthy as a horse. I work on a farm. I run. I play football or basketball or soccer, whatever. I eat a lot of vegetables and all the stuff I hear. Why do I care if I need to get regularly screened for hypertension? Do we know that they're being told the things or not? Do you have any kind of data around that?
I think that's a great point. I would like to ask, who do you think is the entity, organization, institution, or what segment of the society is in charge of that or should be in charge of that? Is that would you think this part of the health system work?
So my opinion,
yes.
I don't know many people in here, but I have an opinion on just about everything, is that should be driven by the primary care physicians. And the question is can, or is it possible for primary care physicians, for instance, in rural areas, we have a lot of them here in Colorado, to, go to school and talk to the students. I have a 91-year-old father who still doesn't take care of himself and do these kinds of things, even though he should, especially at his age. And it starts young. And that's the thing that Healthcare Partners is probably the #1 company in the country at using data to keep patients healthy and creating actionable things with their patients to do that. How do we create that? I think it has to come from the primary care physician, from the parents, and we have to find a way to integrate it into the school system, because it has to be emphasized on all three social fronts, I think. That's just an opinion. I have no data to back that one up either, sorry.
So I think that's an interesting concept. I think it actually interfaces fairly well with the single largest trend we're seeing, at least in the screening data, which is the difference in incentivization and disincentivization, kind of across everything. If you look, there's some variance in the data everywhere. There's variance, between the 4 geographic locales. There's variance within each state between differing population centers. But the single largest percentage variances you see in the data at all have to do with Massachusetts, likely secondary to the AQCs and the massive market penetrance of that there, starting with the single largest payer and then generalizing. And then in Colorado with the I believe that was legislatively driven incentivization, if I remember correctly, of developmental screening and payment and such. And I'd say that having primary care physicians do that work is a great idea. You got to pay them, and nobody pays for that. Nobody pays for that. So
I think as we get more to the state of value-based care, that people are going to, primary care physicians are going to be, my primary care physician is great, right, in this regard. But I don't think everybody's as good. My previous primary care physician kind of sucked at it. But here's the things you got to get screened for, and here's how they might affect your life going forward if you don't do it.
That point did come up in the other states' discussions. As we're looking at the results, it would be important to understand, especially for the preventive measures, what level of patient education exists in the community. We didn't get into the discussion of who's responsible, but from a community perspective, understanding what wellness campaigns could be impacting patient behavior.
And an interesting thing that I think one can see is that it's certainly likely that given time, the numbers can move. So it'd be interesting to kind of dig into this a little bit more. But my assumption would be that in regards to setup from initially starting off as a primary care-based health system, going back to the early 2000s, the West in the country is generally well recognized as the side of the country that really, really hews to this concept. Colorado and Washington in particular, but Oregon, Utah, and a range of other spots. Massachusetts is known to have an academic environment actively hostile to family medicine and to some degree to primary care. And if their incentivization can, over the course of about 6 years, can change their measures on all of these various things to be way ahead of several states on the side of the country actively known for having a primary care-based health system, it speaks to the power of incentivization inside of this greater context. And I think that contextual piece is important to recognize.
I really like the idea that it goes back to it takes a village, because if you don't go to the doctor, there's not much the doctor can do. And I totally appreciate the point that some physicians are better than others about encouraging you to be mindful about regular screenings and things of that nature. But those people who don't go to the physician, don't go to a PCP, are going to be a real challenge. I like the suggestion of engaging with local public health, and Civic is trying to do more of that going forward to get this information on the rates of chlamydia screening out there, to make the public health authorities aware of that information, and hopefully to get them engaged in education campaigns that drive home the importance of going in and doing that. So if local public health can help people get engaged, encourage them to see physicians, then you step up the ability of the physician to really have a meaningful difference in people's lives in terms of encouraging that cultural change. I think that's a really great insight. And we do have a couple of questions from the folks on the webinar. The ends of the sample sizes for Colorado and Massachusetts are close. Percent difference is huge. What is the denominator in each and why? Some of that is there. Well, the denominators are there, and you have to back out the numerators based on the rate. But you see the total number of patients that are reflected in the denominator, even if the numerator isn't specific. So you've got to do a little bit of data manipulation to get at that. So what is the denominator in each and why? I think what we have there are the denominators, and we have to back out the numerators. The other question that we have from the webinar, I wonder if it is not so much the education aspect, but the ease and access to physicians in rural areas, a point that we've heard here in the room as well, absolutely the case. wait lists are long to see physicians, and even trying to get a primary care physician for someone that just moved to a rural area is difficult. And I think, yes, that's absolutely an important point. I know CHI, Colorado Health Institute, Edmund is here in the room with us today, is doing a lot of work, or has done historically a lot of work around that issue, access to physicians in rural areas, and it remains a difficult challenge for Colorado. How do you get practitioners, clinicians to locate in those areas, and how do you encourage them to build lives and stay in those communities or remain invested in those communities long term? That's a discussion beyond what we can directly address here in the room, but a very, very important point, and thank you for that.
Jonathan, can I quickly follow up on the denominator question? I'm sorry to jump in line here. Especially for something like chlamydia, I'm assuming the denominator is everybody who, according to recommendations, should get chlamydia screened. How does the APCD find that? And that may be way too technical for us to talk about here, but is there a variation between states?
Paul, can you give a quick answer to that, or Paul and or Maria?
I can give you the description of the measure. It's for women. It's chlamydia screening in women 16 to 24 who were identified as sexually active and have one test for chlamydia, either whether from the claims or the pharmacy, from the medical claims or the pharmacy. So you use a variety, a really wide set of sexual activity related codes and STD codes and the codes for the screening per se. And
that would be uniform across all 4 states?
Uniform across all states, yes.
And Paul, anything else from your perspective on that?
No.
And Stacy, I know this very question came up in other states. What did you hear in the other states?
They asked us the same good question. How do you identify the population for this measure, and are we identifying the same way across the 4 states?
And sexually active was based on a prescription for birth control. Is that right?
That's one of them. One of the items that goes into identifying sexually active.
And the others?
The others are related if they have any condition that is specific to somebody who has sexual activity, ICD codes that are associated to pregnancy, and ICD codes that are associated to STD. It is really a long list of ICD codes and CPT codes that go into identifying the denominator.
I think I listened into the Oregon meeting, a similar meeting, and there was a lot of discussion around what's included and what isn't, and do the codes adequately capture women in the relevant age group that are sexually active or not? What are we missing as a result of this definition? And are there other measures? Are there better measures? And there was a lot of lively discussion around that. But you're not alone in raising that question. And I think it's an important one. These measures are great, but to George's point earlier, you've got to put them in context. You have to help people understand what they say, and perhaps more important, what they don't.
This is Edmund Toy from CHI. So one of the things that you pointed out is the importance of the economic incentives for providers to do some of these, improve quality in these ways. And obviously that makes a lot of sense from a conceptual standpoint, but I think the big question in my mind is how big of an incentive is big enough? And, when I sometimes talk to providers who are part of Colorado's Medicaid incentives to provide, medical homes, sometimes I hear that, the providers appreciate the additional bump in some of the payments, but may not be really enough to actually change any of their behavior. So that, and I'm not trying to pick on HICPA or anything, but it just raises the question of how much money is enough to change these clinical decisions, and also, is that something you have looked at or will look at, and to what extent are the data there to investigate the size and influence of the size of the financial incentives for providers?
So one of the things that I really, really adore about data, and also one of the frustrations, is to some degree, in terms of using data in healthcare, in a comprehensive, fairly widely cast net sort of a way. We're still largely in, the infancy of being able to do that and having that to be a highly recognized thing. This is, an approach and information that hasn't been around a long time. I can think even a few years ago, if I were at a policy discussion, you would have asked that question, and basically the response would have been from everyone in the room, kind of how we do that. What I would say is that a lot of these things are ripe for design for intervention. So if you have a question about an intervention, intervene. We now have the opportunity to acquire the data to tell you if the intervention worked. So as you're having a discussion, it used to be rates for many of these sorts of changes and pilots and interventions have been set over time, right? Based on what? Based on randomness in most cases, based on experience at best. Level C recommendations, if you will, as opposed to level A or B. Now what we have the opportunity to do is to look pre- and post-intervention to take provider reimbursement as one potential intervention for how to move some of these numbers and see what happens. We can look before, and then we can look after, and we can look at the differences in the rates properly defined. And, as you can see, we can do it across states and across communities, and in various places. And what that allows us to do is then to say, we've had the intervention, we can now look on the other side of it. Let's see what happens. And you can do that in a lot of different ways. You can do it for provider reimbursement. You can do it for an intervention in a specific population around a given social determinant of health, food, transportation, housing, et cetera. Provided that somebody out there doing that work has a patient population that they want to look at and they know the intervention applies to. We can look at this stuff now. And I hate to say that our industry is Byzantine in regards to our use of data, but I'm going to say our industry is Byzantine in regards to our use of data. Not because we want to be, but because we haven't had the data. This demonstrates that the data is there. We can get it back.
So we have a question or a comment from someone on the webinar. Comment, not a question, about primary care. I'm curious if well visits, which are supposed to be covered with no copay or deductible generally, are coded as a complex visit due to checklists and assessment required for sports insurance, et cetera. Just a question, observation for discussion, and a little addition. If the preventive care visit is coded as complex, it costs the patient family more money. And, one would expect, to your point, Edmund, about economic incentives, there's an economic incentive that may be affecting the results here. Taman, thought on that?
I think that is possible. One of the thoughts I had in regards to differences in adolescent screening between rural and urban, I wanted to see if anybody else would come up with it, is essentially, in a rural, when do we see our adolescents for any sort of routine physical? Sports physicals. Sports physicals, once a year. That's about it. So there, is some question as to whether or not every single possible adolescent screening is being coded as such, because a lot of us in primary care, that's when we will get at the adolescent screening. I've had patients leave the room and done a sexual history during a sports physical. I think on more than one occasion. It's sometimes the only time you're going to see that student during the year. So there may be a little bit of slipperiness in the data, but the question is, would that slipperiness apply in kind of all of the different places where the data is coming from at equal rates? I think that's a good question. I don't have an immediate answer to it. I don't know if y'all had anything.
Just a comment to add to the question of have we looked at how much of an incentive makes a difference to performance? And the scope of this project has not as of yet. But one of the themes we heard from the other discussions is it's not incentives on their own that make the difference. It's incentives coupled with transparent reporting within a system, within a community, that those coupled together can really make a difference in terms of driving performance.
And I would also like to add to that comment. One of the aims of the large research project is that once we have the uniform data set, we are going to linking that data set with a data set with characteristics about the health systems and the providers and the networks, as well as the population. So that will give also opportunity, since we are working in 4 different states, to look at the effects of a specific model of incentives or programs in Massachusetts, and then look at the model for Colorado or Oregon, and if those different models of incentives or contracts play a different role in explaining the final outcome, the quality and cost.
Mr. Thompson.
Dick Thompson here. I think a larger question that I have is more screenings often results in more utilization. What's the impact and relationship between Massachusetts' higher scores on some of these measures and total cost of care? In other words, are we increasing utilization and cost through incentives, through more screenings, and then follow-up? If my friend Len Nichols were here, and I can't do his Arkansas accent, but he'd say his culture was if the blood ain't flowing and the bones ain't showing, we ain't going. And I just wonder what the correlation is.
The blood has to be flowing.
Yeah. And so I just wonder what the correlation is between these measures and increased performance on those measures and total cost of care. So has there been any studies about that?
Yeah, we actually looked at that as part of this work. We looked at within the uniform data sets generated across the 4 regions. We calculated per member per month, per person per year numbers, and those were age and gender adjusted, risk adjusted. It was a pretty simple form of risk adjustment, but based on the information that we had about the patients included in the analysis, we did some of that. And I believe it was Utah and Oregon were relatively low cost after that adjustment. Colorado and Massachusetts were relatively high cost. Massachusetts, higher utilization, higher rates, higher cost. That fits. Colorado, sort of middle of the road utilization, relatively high cost, not so well. So we did look at that, and one of the aspects of the project going forward, I'm not sure if we'll be able to do this, but was to generate, health partners total cost of care measures across the 4 states and begin to try and make those connections. So that's definitely on the radar. We've done a bit of that, and the results are mixed. But that's a great point, Dick.
So I wanted to take a few more questions, but I also wanted to indicate we have a whole other section of this to look at. So I wanted to take maybe a few more and then move on to that next piece, because I think there's some interesting questions in there too. George?
Okay, just to the point, I've got a download of the state healthcare expenditure report. It's online at the Colorado Commission on Affordable Healthcare, and it shows that Colorado is ranked 5th in the country at $6,804 for personal health care, and Massachusetts is 49th in the country at $10,600 per person overall, for the state. So, and it is broken out into commercial and Medicare, Medicaid, so you can look at those numbers and see kind of how they're ranked. 47th for commercial, Massachusetts, and Colorado is actually for commercial 38.
One of the things we see here, just quickly, in commercially insured people is very high rates of healthy non-users relative to the other states. That shows up every year. We run the total cost of care measures and compare ourselves to other states. Our rate of healthy non-users is very, very high here. The young invincible, I'm not going to the doctor until I go over the handlebars of my mountain bike and break my collarbone mentality. We have a lot of that here, and it shows up in our total cost of care numbers relative to other states. I thought I saw one more hand. Yes?
About looking at what the total cost of care are, with chlamydia screening, for example, it would temporarily increase your cost of care if you had a positive test, but over time it would certainly decrease your cost. Right? So I think, if you're looking at different measures, you have to look at what the farther downstream effect is for each measure, not looking at overall usage.
Yeah, that's a really great point. That's a great point.
Mm-hmm.
A great point, and very difficult to tease out in the data until you have many, many years of reliable data that you can mine for that sort of information.
But at least now we're working on the data. And speaking of working on the data, let's take a look at prescription drug measures. Once again, if we take a look at the top line, We have some continued patterns. Overall, as we look at that, Massachusetts, is generally ahead. We discussed some reasons for that. And generally, we're seeing, the other states lag somewhat, although Oregon is doing better overall than Colorado or Utah, who both have a fair amount of lag in that. But let's actually get down into the smaller slices, because those are particularly interesting. So if we look at avoidance of antibiotic treatment in adults with acute bronchitis, we again see between large metro and more smaller and rural locations the same sort of a slope, that we have seen previously in regards to our discussion of the screening measures. Does this surprise anybody? Okay. Moving on actually to the next one, which would be, did we follow up as opposed to, in regards to follow-up during the initiation phase of care for children who've been prescribed a medication for ADHD, we kind of see, an interesting pattern here. In, most states, again, we're seeing a bit of a slope downward. Not in Colorado. Look at the slope there. We're not seeing a slope downward that tags the decrease in population. We're seeing a slope upward. Less population, better follow-up for kids who've been prescribed ADHD medication during the initiation phase. Interesting finding, right? Oh, and as we move from the initiation phase into the next one, the continuation and maintenance phase, check that out. Preserves, and continuing to really essentially kind of see a bit of a slope upward, particularly as we get into highly rural areas. So the question is, okay, is that particular to children who are being prescribed ADHD pharmacological treatment or not? Well, let's take a look at antidepressant medication management and see what that looks like. And as we take a look at that, even more clear slope. And again, in contravention to some of our similar size and composed states, and in contravention even to a very different state, Massachusetts. You're seeing a very, very, very large uptick that's very clear, in this particular case, as you move from large metro to rural in follow-up both during the acute, and if we go to the next slide, during the continuation phase for this particular medication. Now, another show of hands, does this surprise anybody? Nobody whatsoever? Okay, I'm seeing some hands go up. This surprised me. I think there may be some reasons for this, but I'm curious to see what people have to say.
So I have a hypothesis, and I'd like to see the correlation between that and the number of people that are coming into the state every month.
Okay.
That could be, I know people who work at the state, and they're issuing 100,000 new driver's licenses a month, and half of those are over 20. So that might be skewing the data.
Okay.
So I think exploring that hypothesis might be worthwhile.
Okay.
Also, another hypothesis is what's the impact of holistic medicine?
Okay.
So like 87% of the people in the U.S. are on some kind of emotion-altering medication, which is a lot. It's a large number. So I used to be one of those patients, but now I have a holistic thing that's gone away, and it doesn't have the side effects. I didn't believe in any of that crap because I'm an engineer and an economic. But, I'm willing to try anything. You have to explore that. So that might be a hypothesis. I can't even say that word. Worth exploring. I don't know.
Okay. No, I think those are really interesting ideas. Other thoughts and ideas? Okay.
But one thing that's not here is the percentage of children who come into a practice who get prescribed ADHD medication. And I wondered whether that differs among these 4 states, whether you have that underlying data. Because, one question for the disparity between rural and urban is if, for example, the likelihood that an urban child was going to be prescribed ADHD medication was significantly higher than it was for a rural child, then follow-up might be less, each person's caseload, they might have a ton of kids who are on ADHD medication, for example, whereas in the rural practice, it might be a much smaller, more manageable number. So, but I also wonder how Colorado might differ in terms of the rate of antidepressant prescriptions and the rate of ADHD.
That's a good point. Other thoughts? Other, possible explainers or confounders?
We've got a couple from the electronosphere. One, Colorado is excellent at using telemedicine for psychiatry. Is this a factor? I think the short answer to that is we don't know, but that's an interesting point and one that would warrant some follow-up. Are we adequately capturing the amount of follow-up that happens via telemedicine? Are people using the codes? Do we see that in the claims? I think that's a great question and a great point, and something that would warrant some further scrutiny. Also, I would like to know, do the rural areas have a higher veteran count being followed by the VA with the antidepressant levels? One of the holes in the Colorado APCD is we don't have the claims data for the federal programs, and no APCD does. The federal government has made it a lot more possible, if you will, to get Medicare fee-for-service claims data, and we've taken advantage of that. But FEHB, Federal Employee Health Benefits, VA, TRICARE, Indian Health Service, some other programs, the federal government has not opened up the floodgates, allowing us to get that information. CIVHC has been working on a partnership agreement with the VA here in Colorado for a couple of years now. We're hopeful that we'll have access to that data and vice versa, and we might be able to begin to explore that question, but right now we lack the ability to do so. But that's a great question, and thank you for that. It's something we need to think about a little bit.
Hey, I just had a quick comment.
Please.
Someone earlier raised the correlation between what's covered under Medicaid driving physicians' practice patterns. Is there anything different about Colorado that might influence this compared to Oregon, Massachusetts, and Utah?
Just, we don't have Medicaid-specific results yet, but I think the project is hoping to move in that direction, and I think that'll help to address your question. But, Colorado has the ACC program. The RICO is giving way to the RAISE. There'll be some changes there. Oregon has the collaborative care program, the collaborative care organizations, which are similar to the RICOs, except the cap it's a much harder cap. It's a soft cap here and a harder cap there. I think the short answer is there are a lot of differences. You've seen one Medicaid program, especially when it comes to eligibility types and benefits coverage. To the extent differences, Medicaid is driving commercial decisions or spilling over into commercial decisions, you're going to see heterogeneity or differences across states as well.
And also based on percentage of market capture of Medicaid in the state. Differences essentially between.
I would like to add, probably, I don't know what you would think about this. The state innovation model might have an effect on this measure also, and the adoption of telemedicine will be one of the features of the state innovation model that can here. I think that was a great point because it's a testable hypothesis with the data that we're gathering, the influence of telemedicine in this rate. Thank you for that.
So another interesting thing that comes up, I think actually everyone here has brought up some really remarkable and interesting possible explanations for the variance of the data, especially in regards to that kind of unexpected, if you will, or at least unexpected by me, pattern of increasing adherence as you move from metro to rural. I'd like to throw a couple of other ideas out there for possibilities. One may be difference in practice pattern. I'm a physician who's worked both rurally and in an urban environment both. Any other physicians in the room who kind of fit that, practice pattern, who worked in both of those? So one of the things that comes up is, what's the availability of a specialist, a psychiatric care specialist in Los Animas County, Colorado? So what's the availability of psychiatrists or other behavioral health specialists in, let's say, Los Animas, Colorado?
Very little. The 20 years I practiced in Ray, there was not one psychiatrist in all of Northeast Colorado past Greeley.
Yeah.
And Southeast is the same.
Yep. and that really is the case. Our behavioral health specialists tend to queue largely to urban and suburban areas in the state of Colorado. It would be interesting to see, what referral patterns are for folks who've been started on a medication for ADHD or depression in primary care, and whether or not they're staying in the primary care practice for further care. That would be an interesting thing to see. Another possibility inside of all of that is, again, do you think patients get more time, or do you think patients get more time with their provider in urban Colorado or rural Colorado? If you had to guess.
I guess rural. More time.
Anybody think urban? So we have about the same. We have rural. A show of hands. Who thinks urban? Anyone? No urban.
We have an online guest that is urban.
We have one online guest urban, and we have, one in the room for urban. Who thinks about the same? We have about 5 or 6 in the room, and we have, do we have any online? Okay. Okay, and who thinks rural? Say about 8 in the room. Any online? Okay. That would be an interesting question, wouldn't it? To really begin to kind of look into. I know what my that I don't have data on. That I don't have data on. But that might be something that a related organization might want to collect data on, and then relate it to whether or not it matches any of these quality measures. That would be something to look at.
I think, and something else, I have a lot of things today I don't have any data on, and that's why I'm hoping you guys would, that cost and the need to drive revenue is driving less time with patients for physicians. My hypothesis is that the costs in rural regions are lower. The impact we have a big problem with physician burnout, especially at the PCP level. That the burnout is smaller because you may not have a commute, and that the people are generally healthier. They're not as exposed to smog. They're not as exposed to, and they have more injuries, right? Because like plumbers injure their hands more than any other profession in the country. I think that all those things contribute to the fact that rural doctors can spend more time with patients. So if I want to come in at 7 and leave at 6, I could have much more time with my patients, not see as many patients, and take my time and have a generally easier time doing it. I am in the suburbs of a large-scale bedroom community. I can't spend more than 15 minutes with a patient if I want to be able to pay my rent and my staff, which just is BS because we put so much overhead on our doctors that they can't practice their craft well. I'm emotional about that one.
One quick comment from a web participant. I've lived both in various states and find in rural areas you see the NP, nurse practitioner, more, and in urban you see the physician more. So again, that access to care issue or by provider type. And Dick?
I would point out that in rural America, the opportunity to have an encounter with your physician in something other than an office environment is also much higher. You'll run into the doc at the football game, you'll run into them at the grocery store, and you get a mini consult, and there's no coding done. It's just that's the way life is out there, and I wouldn't I think it'd be almost impossible to do the correlation, Kumar, that you asked because of the difference in culture and the difference of environment. I think it'd be very difficult.
One more comment. The theory on rural RE cost of care is dependent on where the rural location is. Not all rural areas are created equal would be my interpretation of that.
Hi, I'm Bill Wright. So this maybe opens up a more general question when we're talking about data, and that is that
and that is that a lot of these points are talking about, well, what really happens around the activities that actually have a code assigned to them. And I spent 30 years with Kaiser Permanente and was the medical director, and we were supportive of your activities, but one of our criticisms early, as you probably remember, was that what about all the goo that goes on in between all these various discrete activities that are getting coded, i.e., what's going on in the milieu of the office, what's going on in terms of team relationship, what's going on with the relationship between the nurse and the patient, which sometimes I think in some rural settings there is more of a sense of community or a sense that that's going on. And I still struggle, although I now am a full believer and I applaud the efforts of doing this work, and I think it's been nation leading. I still wonder about the stuff that we're not measuring, or the stuff that's going on in between that, I'm sorry, doesn't have something that you could get paid for and written down. Because I'll give you just a very brief example. When we launched a Healthy Bone study years ago and looked at all the activities on improving fractures, right, in women, we got down to 12 discrete steps, 4 of which would have been codable activities. 8 of them had to do with communication, education, other things that happen between ancillary providers and others. So that to me even comes up when you're talking about something like initiation and continuation of mental health medications. There's other things going on. And I guess what I'm wanting to hear, because right now what we're talking about is we have this large data set, what questions do we want to ask of the data? That's what you're really asking here. And you mentioned intervention. Well, the intervention might be just asking the right question, right? Or doing something and trying to see if something changes. But I think it's more like you have this data and what can we fish in there for to try to find. So is that really your goal, is you're just trying to generate more hypothesis for us to generate that you can go study, or are you really looking for how to measure things differently? Or maybe, I don't know what I'm saying. So,
Matt? Do you want to speak? Do that, Stacey, first?
Sure, I'll start and others can certainly chime in. Absolutely. We're here today to hear from you why you think performance may vary, and what are those questions that we should be asking in terms of structure of provider systems. And that's a key question of this overall project. But there's a lot around that we've talked about today in terms of access, which could relate to structure, cultural, patient behaviors and patient education, et cetera. So this is really a rich treasure trove for us to inform the further research.
So 2 points from the folks on the webinar. Rural near high tourist areas will have higher costs than rural in the plains of Colorado, just to kind of put a finer point on the something we talked about just a little bit ago. And question, does the questioner think these other things result in better outcomes? And can we measure these in claims data? So the off the books, outside of the codes, at the grocery store, at church, at the football game, those kinds of encounters, I would say no, probably a lot of that we can't capture within claims data, but I think it's worth thinking a little bit about how maybe we leverage other data sources to get beyond the limitations of claims. And one more quickly, incomplete thought, as long as we are limited to claims data, we are limited. Actually, that is a complete thought, just no period at the end. But yeah, I would absolutely agree with that sentiment.
And I know we're running out of time, but I just had one kind of general quick question to the room, expanding on this rural and what do we want to ask of the data. In general, do rural physicians tend to maybe participate less in some of the like NCQA certifications or other things that impact the administrative tasks that they are required to complete and then allow them more time to treat patients? Is that something that is, I would guess it is, I just don't know. Mm-hmm.
That's a good question.
Yeah.
That's a good question.
Yeah.
So, please, go ahead.
So just a quick question. So I've grown up with claims doing claim data all the last 28 years. So quick question for you is, where does that information get captured? Like if you walk in and you bump into one of your patients at the football game on Friday night, I assume it's high school. I play high school. And you have a discussion with them about how their back is feeling. Do you go back to the office and you think about that and you jot it in the note? I mean, does it make it into their clinical records or not? No? Because I mean, fundamentally, like, we're never going to catch things out of the air, right? But outside of the claims data, I think the next potential data source is within the clinical records. Right. And within the clinical records, now you can get towards more of the answers of what's being asked. But if our
data will show. If you're going to be complete, you have to have all. You have to have the claims, the quality measures filed for compliance and regulatory reasons, and you have to have the clinical data. Any gap of one of the three means you're missing a piece. Can you be good by having two of the three? Yeah. But if you're going to be really good, you got to have all.
So two quick things here. One, there was a follow-up to the earlier question. Can the outcomes be measured in claims data? So we don't capture these things in the patient record. We don't see them in claims. Can we see outcomes potentially of these types of activities? And I would say not with claims data alone, but to the points just made, if we had clinical information, we could potentially get at some of that. So are some of these intangibles capturable? Not directly, but using a combination of data sources, maybe we can do that. And one other commenter said, I think, was really grateful for the insightful comments that we're getting.
We've got a lot of questions coming in right quick, so.
So how does data capture where services are provided versus physical address of primary subscriber? That one's relatively simple. We have 5-digit zip code and actually street address for individuals in the database, and we use that information to match people up with existing identifiers or to create new identifiers for people who are not previously in the database. We have address and 5-digit zip for providers as well. So we can see not only where people live, but we can also see where people get their care. This one's a little lengthy. I really think in order to get a better understanding of quality, study on quality and level of care, each different insurance company allows. I understand as of this point, getting all insurance companies on board is not feasible. I think the numbers would greatly change in the graphs that have been shown. Just as an example, TRICARE is a great insurance and covers a lot more than some other insurances. We'd love to get to absolutely comprehensive claims data for everybody who's covered in the state of Colorado. That's a heavy lift. One more for FQHCs, which are urban and rural, all are seeking PCMH, patient-centered medical home, and participating in quality of care efforts. Can't speak to the regional health improvement collaboratives or private providers. So just some good insights or additional information that we'll have to think about some more.
But I would like to go back to your comment, because I think you mentioned two aspects, and one is getting lost, because we talk about the environment in rural communities that allows for doctors and community to have regular interactions. But you also talk about what is happening in the practice, and these better, more trusted or closer or tighter teams that allow for better practice. So do you have any other thoughts about that, and how practices, or what in the practices or the health system might be producing better quality outcomes?
Chet, can you pass the mic back again? Thank you, kind sir.
Well, I'm going to stand back away from this because I'm afraid it might attack me. First, I have to do a disclaimer that I have some huge biases here on the way medicine is arranged and delivered. Obviously, I drank the Permanente Kool-Aid for a lot of decades. But I think as long as we're living in a situation where we are paying discrete activities that are delivered principally by physicians only, we're going to be limited in understanding the full range of what the team impact can be, because what the MA can do, what the LPN can do, what the RN can do, what the health educator can do, what the PharmD can do, et cetera, et cetera, et cetera, et cetera. All sometimes, and I'll give you my strong bias, is that we as physicians are oriented on what's wrong with you today. We don't think in terms of wellness, and that's just been the nature of our training. And when you are surrounding the physician by a team of people that actually are more focused on the proactive, what can we do to minimize the number of potato chips you eat tomorrow, rather than wait for someone coming in needing a huge amount of diuresis with their heart failure. I mean, I think it's trying to get an idea. Now, obviously, my bias is that we will not arrive until we really talk about payment reform. I mean, this is really where this is ultimately going, and as long as we're going to continue paying these discrete little pockets of activities, we're going to keep getting the kind of results they are. So I'll stop it.
And with that, actually, I'm looking at the time, and it looks like we're kind of coming towards the end of what we're doing. I did kind of want to give a concluding statement, but wanted to see if I see you leaning in. I think you. No. Yeah. Just wanted to see if there were any just burning things anybody had to kind of say.
I'm a big proponent of social determinants of healthcare, and there is a data set downloaded to Colorado Commission on Affordable Healthcare of the county health rankings, where you can select a county in Colorado and look at the profile of these social determinants of healthcare, one of which I think is percentage of STD, things like that. And I would urge all of you to look at that as a context for all of the work. Because to me, it's at the end of the day, it's accountability. There isn't anybody that's accountable for the large metro areas. That number would not be in the hands of anybody like a responsibility. Maybe Colorado Public Health or something like that. But at the county level, where you have a community health assessment required, and you have stakeholders from doctors and hospitals and educators, it's critical to provide that data at the county level where real action is going to be maybe possible. Just one other quick one is CDC has a thing called the Alliance for Health, where they provide a school health program kind of package. So a lot of your measures would actually get captured if there was a standardized school health program that would, I think it kind of points to the collaborators and partners that you have, outside of healthcare, educators in particular, and school health.
Okay, much appreciated. So, one more. Then we really do have to stop.
I'm 74 years old, and I got to get this said before I forget it. The young people that I'm interviewing to be medical students, prospective medical students, almost every one of them has done research in these days. And many of them want to be primary care physicians. But they say, how am I going to do research as a primary care physician? I point to them. I remind them that in this day, in order to survive in medicine, even in Ray, Colorado, you've got to have EMRs. You've got to have electronic medical records to survive. This is a data source with which you can do research even as a primary care physician. So this gentleman's suggestion that we look at clinical records as a part of our research, that's essential in the rural area, because your claims data is not going to be reflective of the pattern of care. And so that's the input that I have, is that you will facilitate data collection from the rural areas if you look at you work with the physicians, PAs, nurse practitioners, everybody, and look at clinical data. Now, how you do that, you're going to have to figure that out. What's the system? How do you do it? Do you recruit people, recruit the physicians to do this? But that's where the gold mine is in the rural areas, in the clinical data, clinical record.
And thank you for that suggestion. And really, to kind of bring all of those last few comments together, what I'm hearing is we want more. We want more data. We want more specificity. We want more completeness. We want to be able to look at the squishiness, to kind of use the term from over here. And really what, I always do when I look at data is, well, what is data? Data is a tool. It's a scientific and quantitative tool. Let's think about some other scientific and quantitative tools throughout history. Started with the spyglass, from there to, Galilean telescopes, from there to astronomical observatories. We eventually got to the Hubble, right? Microscopes the same way. Van Leeuwenhoek's little tiny ground glass thing where he held it up to his eye, to an average microscope. We think about electronic microscopes that can see, atomic and molecular structures. Tools progress over time. Tools get better. But let's think about where we are realistically. Probably somewhere around the Venetian Renaissance in American healthcare when it comes to using data. Forms like this are really helpful for us because it helps us understand how to move from that little tiny microscope you hold up to your eye to something that's going to be a little more comprehensive. And I think that is something we really value, and we thank you all for that. We also want to say, don't let the enemy be the purpose of the good. We have some data for you right now. It's not everything we'll have eventually. We're not at the Hubble yet. But if we can get you up to the ability to see a star you've never seen before, we're here for that. And we want to be able to help you do that. So continue to come, continue to for us, continue to help us build the better telescope and microscope, and look through what we have now.
Yeah, I think a couple of things. There's some uncertainty around this. When the grant was awarded, it was a 5-year grant. We submitted 5-year budgets, and we were all set and happy and ready to go. And then the administration changed, and we were told to be prepared for a 50% budget cut, and there might not be any funding at all. We ended up being fully funded for year 3 of the grant, but there's no guarantee that years 4 and 5 will be funded. So Emory, as well as the 4 participating states, are mired in a little bit of budgetary uncertainty. There's also been some changes in what the 4 states are going to be doing moving forward. The thing that the project wants to get to is, it's great now that we're seeing this variation by geography. We're seeing this variation across states. The real goal of the project is to get to variations across whether or not provider groups are owned by, and ideally, this is a really hard nut to crack, affiliated with larger health systems. So does performance on these measures differ for practices that are owned by large health and hospital systems versus systems or provider groups that are independent? So we're still trying to get to what we think is a good set of indicators for whether or not a physician or a physician practice is owned by a larger health system, and to begin to drill down into the data on that level. We want to take the cost information further. And Stacy, I don't know if you want to chime in on some of the things that we have envisioned for year 3, but that might be helpful.
Yeah, sure. Thank you. So we'll be back to you. So I think that's part of your question. Is will we continue this conversation? That's absolutely the goal of today, was to share the project with you, get you started in terms of sharing some data. You provide us with insights which have been tremendously valuable. The measurement work will continue. The way it's being approached by the overall project is changing a little bit, but the measurement work will continue. So we'll continue to have results for different data periods and additional measures to bring to local stakeholder groups for your input. We also are partnering with Dartmouth to do a health system survey. So we're identifying samples that aren't included in the Dartmouth sample, fielding that survey in each of these 4 states, along with some follow-up interviews to really get at what are those attributes of health systems that make a difference on performance. So we'll be reaching out to the community in a few different ways, sharing results, surveying,
and I love, Taman, your analogies at the end for the evolution of science and technology and our ability to see things. I'd just like to take a minute to thank everybody for coming, thank everyone for joining us on the phone. This has been enormously valuable. All the 3 meetings that preceded this were really terrific in terms of getting feedback from the community on issues that we need to consider as we get beyond the baby steps of doing, 8 quality measures. We see how the results vary across the 4 states. We dug into urban versus rural a little bit. We're going to get to the level of health systems. We'll be sharing that information as we generate more and more of it. But thank you all for joining us today. bearing with our sort of toddler-esque level of development to this point, and we really look forward to continued collaboration. But with that, I will thank you one more time for joining us today and let you get back to your day. And if there are things that occur to you as you're driving back to your office or in the middle of the night or whenever, we're always around at Civic, and please send us an email, shoot us a phone call, reach out to civic.org, keep your eyes on our website. We'll be adding a lot more public content to that website going forward over the next year or two. And again, just thank you so much for taking the time to be with us today, and hopefully we'll be in touch soon.